Good evening, and welcome to Health Plus Weekly. I am Dr. John Pacoa. I'm joined by our co-host, nurse practitioner Hannah Raymond, and we are excited to have Dr. John Stamoulis, a local neurologist, in the studio with us tonight. John, thank you for coming out.
Thank you for having me.
We hope everyone had a great Memorial Day weekend. We are excited that finally summer weather has arrived. So tonight's show, we're going to be talking about, today is actually May is stroke month, so we're going to be talking about strokes in terms of how to hopefully prevent as many strokes as possible, how to identify if you are having a stroke or a loved one is having a stroke, kind of what the treatments of, acutely when a stroke happens and afterwards, how to reduce your risk of having a stroke again. And if there's time in the show, we can also, we're going to talk about headaches as well, which is an area of expertise for Dr. Stamoulis. As always, we encourage you to send your questions in via Facebook. Hannah's on the laptop, looking forward to hearing from us and for the questions in terms of strokes for Dr. Stamoulis and us tonight. We'll do our best to answer all your questions. Also, as always, if you have general medical questions in terms of primary care, focusing on adult topics, Hannah and I are happy to field them. As always, we'll kind of wait to the end of the show if that's okay with you, and we'll answer them. So please send your questions in. We also like to hear where people are tuning in from and watching on the show, so please drop in, say hi, let us know where you're watching from and how your summer's going thus far. A couple announcements before the show that we want to make sure people are aware of. We're excited to announce that St. Luke's has a new wound care center at St. Luke's Hospital. This is in addition to the Southcoast Wound Care Center in Fall River. The wound care center addresses all types of wounds, from diabetic wounds to kind of pressure wounds and a host of other injuries that are difficult to care for. Personally, as a primary care doctor, I know Hannah and I have referred many patients to the wound center, and they do fantastic jobs of getting difficult wounds to heal and are a great resource to patients. They have multi-modal ways of treating wounds, including hyperbaric oxygen chambers, which are fantastic. The oxygen chamber actually will remain in Fall River. That's the one thing the local center in New Bedford won't have. But though for our patients who are in the greater New Bedford area, this is a great convenience to not have to travel down the Fall River to receive their wound care. Second, we want to make sure people are aware that in terms of educating people and just kind of getting you up to date in your health, that the Southcoast has added resources to our website in terms of topics and general information regarding certain health topics. Certainly when we see patients, I'm sure you do too, John, in the office, a lot of people are scared. They turn to the internet, they're researching things, and there's good information on the internet and bad information. So we are trying to collect just kind of a safe, valid resource for patients to go to learn about their diseases, and that's on the website. Also, we want to make sure people are aware of the number of support groups that Southcoast offers, from losing a loved one to postpartum depression to kind of getting over cardiac disease. There are a number of support groups that meet at different times and locations throughout the month throughout the Southcoast community. If you turn to our website, you can look at them and hit the resources tab to find the calendar where there's a support group in your area. And one last thing, as we are approaching, I can personally appreciate this, summer camp time, forms and physicals that have to be completed. I just reminded myself that I have to complete the boys' forms before June 1st for their camp.
Make a note.
Make a note. Our urgent care centers are open and willing to help you complete with some of the physical forms. So you can go schedule an appointment online, and for people maybe who have waited to the last minute, like myself, our urgent cares are ideal at helping you getting those sports physicals done, in addition to the other kind of bumps and scrapes and things they're happy to help you with. Again, and that's at southcoast.org. You can see where the urgent care locations are, including our newest one in Lakeville, and also if you go to our website, you can help with scheduling those appointments so you don't have to wait in line, which is great. So with that, John, we always like to start with our guests, just to tell, if you could just tell us a bit about yourself, how, where you're from, how you wound up in medicine, and then, perhaps neurology, and then what brought you to Southcoast.
Sure. Well, I've always had, obviously, the cliche thing here that everybody says that they haven't had an interest in medicine. I just couldn't see myself doing anything else but being a physician. But nevertheless, I did my training at Rhode Island in neurology, but prior to that, while I was in internal medicine, I didn't have any inkling that I was going to get into neurology until I rotated on the ward and started seeing the dismal issues related to stroke. This was all prior to TPA's evolution. I was watching our cardiology colleagues, how they were light years ahead of what we were doing in the stroke world, but at the same time there was research being done with the thrombolytics and other things from preventative medicines, et cetera, that led my interest into pursuing this thing. So after doing a couple of years in internal medicine, I switched gears and went into neurology with the hopes of pursuing a stroke fellowship. And did everything, all that training at Rhode Island Hospital.
Oh, wow.
Great.
Yeah. Thereafter, it was at that year, 96, that TPA got approved, FDA approval. And everybody was just trying to jump on the bandwagon with stroke centers. So I got recruited in Tennessee to help put together one of the first community-based stroke centers.
Okay.
And let me tell you, it was quite challenging, but very interesting times. And after a few years of doing that, I just decided to return back to our roots here in the Massachusetts area.
Did you grow up locally around this area?
I grew up in the West Roxbury-Rosendale area.
Okay.
But I had an uncle that practiced here, urology, that sort of coaxed me to come over here.
Okay.
So that's what brought me to the Southcoast area, and I've been here since 2004.
Wow.
Yeah.
And we're very happy. We have a couple of people already saying that you're great and they love you, and
sure.
they're thrilled to have you as their doctor. A couple other people watching from Dartmouth, New Bedford, and one from New Hampshire, Donna. So I think we've branched outside of the South Coast region.
Thank
so
you, Donna.
That's great.
Thank you.
So where do you practice now? Where is your office now?
At 480 Hawthorne Street there with Brain and Spine Center.
With the brains.
It was a very, very interesting move where I came from. We got acquired from New Bedford Medical Associates, if you recall. Got acquired with Southcoast Hospital, and now we're integrated in this neuroscience center, if you will.
Which is nice, right?
It is absolutely one of the best things that I could have done, I could say. And I will say this, when I was in my first part of my career here and got recruited, as I said, in Tennessee, it was kind of the concept that some progressive thinking neurosurgeons try to do is the same thing, but the problem was that it just didn't materialize from an administrative standpoint. It kind of broke apart. But all the while, this was really the driving force for me, was to get into something where we had the whole neuroscience concept under one umbrella. And fortunately enough, with the help of a few, particularly Matt Phillips, et cetera, spearheading this thing, really got this thing together, and I'm very happy and honored to be part of this thing.
Yeah, we feel really fortunate too in terms of so much of a medicine is increasingly a team-based sport, and we've had members of the physical therapy team from the Brain and Spine Center on the show, and because it encompasses not just physicians, physical therapists, neurosurgery, neurology, correct? Pain management's a little bit involved with
Absolutely.
You guys as well.
Like I said, the whole thing is under one roof where, like I said, physiatry, pain management, neurosurgery, we have clinical neuropsychology, neurology, and the physical therapist on the other end of this thing. So it is a one comprehensive center.
Good.
That's correct.
So in terms of just kind of starting, we always like to just kind of break it down in terms of explaining the diseases, and maybe in terms of people may not, make sure they understand. So stroke, we hear it probably, pretty common on television in our lives. Most of us may know a relative who suffered a stroke, but just for the people listening, in terms of what happens when someone suffers a stroke, from them kind of a patient perspective to kind of explain it.
The basis is the lack of blood supply to the brain for whatever reason, and consequently it causes death to the nervous system, the tissue in the brain. When we talk about the stroke, sometimes there's a word thrown out there, this TIA and stroke concept.
Or a mini stroke, right?
So the mini strokes and what the differences are. And I think that's kind of important to illustrate that.
Yes.
And when we're referencing a TIA, it's, as it stands, transient ischemic attack, and essentially it reflects a reversible neurological deficit. So you may have symptoms that mimic an exact stroke, but if these symptoms resolve within 24 hours, there is no death to the nervous system's tissue, if you will, and there's full recovery from that. Much the same happens in the stroke, that you will have blood supply that's restricted or devoid in a particular area, and there's a center of where the blood supply has not been restored within a certain time frame, and so the tissue dies. Absolutely. What we try to do in stroke and all the interventions that we're attempting is to try to reperfuse the area of the tissue that surrounds this particular center of death. and restore function. And so minimize really what comes out is the deficit. So when we're looking at the stroke itself, there will be absolute an area that will have dead brain tissue, but the point is to try to limit the amount of adjacent tissue death, if you will, from that.
And the damage.
So the main difference between a TIA and a stroke is the TIA has reversible symptoms. The symptoms do not last, and there is no actual brain cell death, whereas in a stroke there is actual damage to the tissue.
Correct.
Okay, so when somebody's had a TIA, is that a big warning sign that they need to kind of watch out for a precursor to a stroke? So what types of...
That's the important thing,
Right.
that it's not to be taken lightly. That is probably your only knock on the door, that something needs to be done about it. You don't say, well, I'll sleep it off and it's going to go away, or it did go away and it's not going to come back, because the reality is that 50% of the strokes occur with a TIA preceding this thing. Around 1 in 20 will actually go on and have a completed stroke.
They will.
So it's a very big issue in terms of how do you proceed with a TIA. It's not as benign as somebody may think, that because the symptoms have gone away.
Yeah, I think that's an important lesson or a point that people who are tuning in and listening to tonight is just that if, and we'll talk about the symptoms in a second, but if you have some of these symptoms, which they can include things like trouble speaking, correct? Maybe a weakness or trouble eating. Sometimes people notice that they're having trouble with one side or the other. What are some other kind of symptoms in terms of that you see in your practice where people just kind of...
I think what I try to convey to the patients is that if there is anything that's new, different, neurological, regardless of how subtle it is, you need to bring it to our attention. It's our business to try to figure out whether this thing has credibility or not. I don't want you to, particularly like to look at the elderly population, a numb hand or a little droop on the cheek, and they say, well, go sleep it off, and the next day they wake up with a complete paralysis on one side of their body. I know that as we try to educate the community, they have the algorithm fast, face, arm, speech, and then time, call 911 and get to medical attention quickly. But everything else should not be overlooked as well. And the subtleties are things that need to also be brought to our attention. Your blood vision, your sudden headaches, things that are just not common in terms of your day-to-day
how you feel
ailments.
normally.
Right.
So in terms of kind of other warning signs, if somebody is experiencing those symptoms and it's office hours, what would you recommend somebody do first if they kind of notice a subtlety and a change in their vision, or a little numbness in their face or arm, or a little facial droop? Should it be right to the hospital?
Well, as you see, we have the interventional procedures now with what we do with thrombectomies, and there's also the TPA. So the issue here is time is of the essence, right? So you do want to bring yourself to medical attention as soon as possible. Again, if this isn't something new from your baseline, don't wait to sit and make a phone call the next day, or wait for a return call from the nurse on your symptoms. It really should be brought to medical attention immediately.
What's the window typically? You just want to make, and I guess in two is maybe why is it so important that it gets treated sooner rather than later? We know there's it's 3 hours typically from the symptoms begin. Is it because that you lose the ability to reverse the deficits if you go beyond that period of time in terms of, so people know that? Is it?
So as we mentioned earlier, that if the brain is restricted from blood flow for a certain period of time, that particular brain tissue is at risk for cell death. So the sooner you get to medical attention, and we have these interventions with IV TPA and thrombectomies, there's a strong possibility we could reverse these processes and minimize the damage. With the use of TPA, which is one of the treatments we do for acute stroke, the time window is up to 4.5 hours, and then you get into what they call the large vessel occlusive events that they have windows up to 24 hours to treat for clot retrieval. Regardless of the case of how you're going to get treated, the point is that you shouldn't be thinking about these things, but rather bring yourself to medical attention and let us kind of deal with the direction of which way that you need to be treated.
Yep. So if it's during the day, perhaps call you can reach out to us, our primary care doctor, or, if you're already established in a neurology practice, maybe, but if not, don't wait on it, maybe, right to the emergency room.
I'm sorry to interrupt, but even with that, when they give the call, and this is something different from what we know this patient at baseline, we don't want to take the time to try to sort this thing out in the outpatient setting. We tell them, go to the emergency room.
So this is really an emergency room,
Absolutely.
Absolutely.
I understand that prior to TPA, I'd like to emphasize this point, we did not have anything to treat stroke, the acute stroke. All we were doing is to stabilize the patient and try to prevent the next one from happening. Now, since '96, with the approval of TPA, this is the only thing, these are the things now that we can do to minimize the damage here.
And then for people listening, or watching, TPA is just a total game changer in terms of it goes in, it breaks down the clots that are in the brain, kind of in almost like a
clot busting,
a clot buster, you know what I mean, or like a Drano for the arteries, in the simplest sense that you put this medication in, and it works through these clots and restores the blood flow to the brain. So it was a total, it just made treatment so much, revolutionized it, correct?
It certainly did. It changed the thing. In fact, at the time, early on when TPA came around, just prior to that, we were looking at stroke being like the third, fourth leading cause of death. It's dropped down to the fifth, but still remains as the #1 cause of disability in this country. Still remains.
And in addition to medications like TPA, there's other, now there are proceduralists who can go in and retrieve the clots, right? Correct?
Correct. That's what we're referencing, the large vessel occlusive disease for the big thrombus that they go in and do the clot retrieval on that. Then we talk about other aspects of treatment, interventional treatments, where you can do the surgery for the carotid arteries, carotid endarterectomy, stenting, and then you get them onto medical therapy for preventative treatment for stroke.
If we can back up just a little bit, something we also like to highlight is for people, who is at risk, higher risk for having a stroke. So before you even get to those symptoms, what type of chronic diseases increase people's risks for having a stroke to begin with, or having a TIA to begin with?
That's a good question. So the big risk factors usually are what everybody faces: cardiovascular disease, etc. Is the high blood pressure, your tobacco use, cholesterol, your weight. A lifestyle, of course, lack of exercise, etc., leading to obesity, diabetes. So these are the big standards that's across the board for all vascular diseases.
So we've talked about that in heart disease, we've talked about that in peripheral vascular disease with Dr. Lin. And
cancer as well, it actually is now, the same risks are present for cancer as well. So it's nice in the sense that there's just not multiple things people have to learn to
stay healthy.
Correct. It is the same, the CDC outlines them. I think the 4 behaviors that lead to almost all the illness in adults in this country. It's smoking, excessive alcohol intake, inactivity, and being overweight. And so those things. And we've had, Dr. Rocha, cardiology on the show, and talking about the importance of just knowing what your blood pressure is, because a lot of people don't know what their blood pressure is if they're not going to the doctor. I mean, it's kind of a silent killer in terms of walking around, and you could have an elevated blood pressure. So,
unfortunately, the things that we're looking at, what we just described here, are the modifiable risk factors, and there's clearly another category of the non-modifiable risk factors. So your age, your gender, your genetics, and the fact that you even had a previous TIA or stroke is also another one of these risk factors, but a non-modifiable one.
How strong a family history does it play in terms of
Well, I think it looks at early vascular disease.
Okay.
And certainly atrial fibrillation, is a huge,
Absolutely.
One of the main reasons we treat atrial fibrillation and with anticoagulation is to prevent stroke. So certainly people with atrial fibrillation are at higher risk of a stroke as well. We do have a question from Katie. Hi, Katie. We miss you in the office. Do the signs and symptoms differ from male to female in terms of the stroke presentation?
No.
No.
They're pretty much standard.
Same. Okay.
Which is good, because heart disease presents a bit differently. Women can present with different symptoms. I think your point too about just being really conscious of how you feel and your body feels, and if you have these neurologic symptoms, meaning like you trouble speaking, numbness, tingling, and weakness, but also like with AFib palpitations. If you're noticing that all of a sudden you're, having funny heartbeats, especially when you're lying down in bed at night, or you're getting short of breath, it could be a sign that could be, underlying atrial fibrillation, or there's irregular heartbeat that causes a significant burden of, stroke as well. So for our patients listening to kind of, it's another thing probably not to ignore and get checked out.
Well, that's the curiosity, that sometimes you may not have the symptoms, and it's only through the investigations that we do that we discover these things. Even with the atrial fibrillation, that you may have something that, what we call an embolic event. At the time of the evaluation, your EKG looks fine, but it isn't until they put one of these recording monitors in you and discover later on that you do have atrial fibrillation. So again, that's why the importance is to get yourself to medical attention, because we're trying to find the cause of this thing and prevent the next one from happening.
And Hannah, on a personal note, you unfortunately, but and also in a positive way, in a good way, just experienced this, right?
Yes. So this is kind of a good illustration of soup to nuts stroke presentation. My 96-year-old, otherwise pretty healthy grandmother, she has a history of high blood pressure. So, like you said, one of the risk factors was eating breakfast, and my uncle witnessed her kind of with a facial droop, had trouble speaking. Her arm went numb. And he noticed it immediately, called 911. She was transported to actually Rhode Island Hospital, where you trained. And then I think I was in clinic and got a phone from the emergency room, doctor saying, is it really possible that she's this healthy, and kind of thinking about the things that would preclude somebody from having that clot busting medication. What are some, things that we always like to think about, also like things that are important for everyone to know. So if your family member is suffering a stroke, and maybe you're being asked to if they have any contraindications for a clot busting medication, is there anything that people should know about that?
Well, I don't want to impregnate their minds with things that they shouldn't. I think they need to, again, bring themselves to medical attention, because you bring up a very good point. Right. 90 plus. In the past, when TPA came on board, there was a cutoff in age. 80, I think, was the cutoff max, but now they've looked at this thing and say, no, there's no an age limit thing except under 18, pregnant, those kinds of things, of course. But even the degree of deficit, previous to that, we had a certain score on the NIH stroke score, and they said that was a very severe stroke and a risk for what they call hemorrhagic transformation, so they precluded them from receiving TPA. But this is not the case. Subtle symptoms, major symptoms, doesn't matter. If you're meeting the criteria, you'll get it. Administer the medication. So she did. She received the
TPA, was under careful monitoring for the next 48 hours, and she's back to her old funny self. So
symptoms went away, right?
Symptoms went away. Yep. She her speech returned. She's eating, was eating Girl Scout cookies the next day, and drinking apple juice, and up and walking. And so that's kind of, we were grateful for, the fast recognition, and then the treatment that was available too. And now I think that kind of, so her symptoms did go away, and so, but another important thing that we're now dealing with is kind of the after, the after therapy of the stroke as well. So you mentioned kind of some important medications that people should be on after having a stroke. And then certainly, the therapies that we'll talk about too. So after a stroke, high blood pressure, important to control, high cholesterol. Is there any other, medications that people should, if they're not on after stroke, should maybe, bring to their...
I think those are the important ones, the blood pressure, cholesterol, and they address that almost immediately upon arrival in the ED department. Should they be on an antiplatelet agent like aspirin or one of the other medications, Plavix or Agrinox? These are things that they decide during the evaluation process. And of course, we look at whether or not the stroke was some big clot that went up there. Thinking of atrial fibrillation, should they be anticoagulated, also needs to be addressed. At the end of the day, though, the patients typically are placed on or have some form of a antihypertensive medication and the lipid-lowering agents. The criteria, the cutoffs, has actually been changed. In fact, I think they were using LDLs of 100 before, and now it's gone down to 70. So these are, and I think that when you look back at some of the data, and I want to kind of get into all the scientific academic stuff, but the point was that even those that had normal blood pressures and normal cholesterol levels, if they were placed on these medications, still showed to have some risk reduction in stroke. So it's important that these factors, and of course controlling blood sugar, and then you start getting into things like weight and other lifestyle modifications, correct?
In terms of identifying what caused the stroke, it's important. How good are we, in terms of, so where, where the blockage came from or what caused the blockage, so a lot of times it can come from the neck, right, in terms of do we have, plaque buildup in our carotid arteries is one source. Whether you were in this irregular heartbeat, like we talked about atrial fibrillation, it's important, correct, in terms of reducing your risk of having a second stroke or another stroke.
Correct. You could potentially make an inference of the kind of stroke, and when we talk about the strokes, the different types, the ischemic, the one with lack of blood flow, or the hemorrhagic type strokes. And the vast majority of them, of course, 80% of them are the ischemic type strokes. And their origin can start anywhere from the heart, as we call it, the embolic events, and then you get into the thrombotic events. So these are the plaques in the arteries and hardening of the major caliper vessels, and then deeper into the brain when there's secondary changes related to blood pressure, blood sugar, and cholesterol, etc., that those two will harden up and shut down. So there are actually different mechanisms causing the same thing of the ischemia aspect of it. So a big blood clot comes from the heart, blocks a major artery, and then you have a very large stroke. And it's very evident when you look at the CT or the MRI. There are small size strokes that lead you to understand that this is probably a thrombotic event, although you can have blood clots that break up and sort of block up some of the medium or small caliper vessels. And then clearly the things that we call the lacuna, the deeper strokes in the brain, are essentially related to that of the long-standing issues of hypertension, diabetes, hyperlipidemia. So the approach to the treatment of these things are a little different relative to the mechanism of the stroke. Clearly, regardless of the mechanism, most all patients kind of go through a uniform evaluation to look at the heart, study the anatomy of the vascular anatomy in the neck and the brain, and then make a determination from there what could be the potential mechanism, how to prevent the next event from occurring.
And to diagnose a stroke, usually just kind of working down from the head down in terms of the things that people go through, a CAT scan, but also an MRI, correct, in terms of showing the what damage has been done, correct? And maybe you can talk a little bit about the pros and cons of each one of those tests.
So when you're arriving to the ED department, because again, time is of the essence, they don't necessarily want to be wasting the time getting the MRI because of the time factor, although it is a little bit more sensitive to show very early changes. You get the CT scan, which kind of screens out whether this thing is a hemorrhagic or an ischemic event. You may not appreciate changes immediately on the CT scan, but at least it lets you know the difference between what you're dealing with, an ischemic versus hemorrhagic stroke. Thereafter, when you want to delineate further the type, the extent of the stroke, you get the MRI. And then after that is looking at the potential mechanism. So you start looking at the vascular anatomy, interrogating the heart.
I think you said an important distinction there. So there's the strokes that occur because of lack of blood flow,
Correct.
and then there's the strokes that occur because of like a burst blood vessel, so the hemorrhage. Is the presentation between those two types of strokes different?
Again, it affects the brain much the same way, and you're going to have similar symptoms in presentation. You don't know what subtype of event, whether this thing is a hemorrhagic or an ischemic stroke relative to your clinical presentation. And again, although they talk about the cerebral hemorrhages, subarachnoid hemorrhages being these sudden headaches and so on and so forth, we have seen presentations that will fool you and think that this was an ischemic event, and you turn around and look at the CAT scan, boom, there's big blood sitting in there.
And it's really important, I mean, one, for just getting treatment. Like, so if you have these symptoms, go to the ER, get it teased out to what it is. Two, for people to understand, though, to go, because they might have a relative where they said, oh, they just took aspirin, so maybe I'll do that. But if you're having a bleed, I mean, it's very different treatment, God forbid, right? If you're having a stroke and it's a bleeding stroke or hemorrhagic stroke, the last thing we want to give our patients is something that's going to thin the blood even more, versus if it's a blockage stroke or ischemic stroke, you're talking about the TPA medication. So super important in terms of just treatment, just identifying, making sure you go to get it even identified correctly.
Absolutely.
We've another question from Katie. Once you have one stroke, what are the odds that you'll have another one in the future? So you said 50% of people who have TIAs will progress to having a stroke, but once you've had a stroke.
I think the best way to view it is that once you've had an event that you are at risk, so it puts you at that risk profile. Remember, we talked about modifiable, non-modifiable, so it is a risk factor now. So you're not
another notch in that category.
So exactly. Yeah. So even in the best of scenarios where they've identified the mechanism and put you on medications or whatever they have to do to prevent the other one from happening, the fact that you had that event increases your risk for another one.
Mm-hmm. And then once we kind of look at where the stroke occurred in the brain with the MRI, they can help, and then they kind of figure maybe where the source of the clot came from or might have caused it. Mm-hmm. Carotid arteries are very common, so people often look at to see if they have carotid disease, and if they do, it's good because actually they can reduce your risk of stroke if you're found to have a degree of plaque in your carotid arteries, correct?
That's correct, and they usually intervene once they determine if the degree of stenosis blockage is greater than 70%, and it is the side that's causing the symptoms. They can intervene, either do the surgical endarterectomy, as they say, or stent this.
Yep. And we had actually Dr. Pinn on the show a couple weeks ago with Hannah talking about our vascular surgery center, which is a really tremendous resource to have embedded in our team as well. They do these surgeries right here at St. Luke's Hospital, and depending on how severe it is, they've got it down to a really nice, kind of process where it's not terribly invasive, doesn't take a terribly long time. They have great outcomes, right, Hannah? Mm-hmm. Did he talk about that at all?
He did, yeah.
Now that is the great advantage we have with the collaborative efforts of all the subspecialties. Like you say, Dr. Pinn and Gillespie, a quick phone call, I have a patient here that I think is the real deal. Within hours they'll be seeing them. Much the same with our cardiology calls, there's a lot of communication back and forth. So we are in a very fortunate situation here with Southcoast Hospital. Mm-hmm. And the subspecialists. Yeah.
So we have another question from Robin. So we've talked a lot about TPA, but she's just asking, could you describe what is it?
So TPA is a tissue plasminogen activator. In your body, there's a natural circulating clot-busting thing, the plasmin, in a plasminogen form. It's in a neutral form, and when you put in the medication, tissue plasminogen activated, well, I don't want to get into the scientific part, but it actually activates plasmin to do the job of lysing up the thrombus. Interestingly enough, the plasminogen is highest in its concentration early on in the stroke and then starts dissipating. And this is part of the reason why we try to get folks in sooner than later, aside from the fact that you're trying to reconstitute blood flow in the areas of the brain tissue so that there isn't permanent damage, but at the same time to be more effective in terms of its effect of TPA on the plasminogen. So the basis is here is to activate your normal plasminogen.
Yeah, because our body breaks down clots every day, all day, right? And as part of our normal cell function, we do this naturally, so it just kind of helps the process kind of be more aggressive.
That's correct.
Yeah.
So you spoke about some of the other procedures that somebody might need, so clot retrieval. Could you describe that a little bit more?
So the strokes where a blood clot lodges in a large vessel, you can actually see this thing on the CT angiogram, so that's one of the things that they would do in the evaluation process, and they identify the area where a large clot is sitting in one of the medium or larger size vessels. They will float a catheter to there where there's a retrieval device, a wire retrieval device that will go on the other side of the clot, and they pull back and retrieve the clot. There's other suction devices that have come up as well, but the basis here is to try to retrieve the clot intraarterially and restore blood flow. If you look at the studies, what amazed me is that in both pivotal studies, they actually terminated them early because of their effect.
How good they worked.
Wow.
Exactly, and it's rare that you kind of get that in medical studies.
Usually the opposite.
Yeah, we're waiting there years and years for end results, and the results are usually, they say statistical significant, but these are very minor numbers. This thing was quite impressive, and in fact, on the anecdotal side of this thing is that we have literally seen patients go from complete hemiplegia to we're back to restored function.
Yeah.
And that is so impressive. More impressive than TPA, I may add.
So somebody would be a candidate for that if it was a
Large vessel.
And an actual visible clot on the imaging.
And they identify this thing, right, with CT, with the angiographic procedures.
So they can.
Actually, like my mother-in-law had that, happen in August. She was out to dinner and, similar presentation to Hannah's grandmother. Eating went down. This was in Florida. They rushed her to the emergency room immediately. She was just a half hour away from it. She had new onset atrial fibrillation that she was not aware of. Had a big clot, middle cerebral territory, and they retrieved it, and she's doing really well. Afterwards. There were some deficits left, but it really is. I think for me in medicine, one of the nice kind of clinical surprises is how well people can recover after a stroke or a CVA in terms of, they have a big deficit to begin with, but they're treated early. And sometimes even if they don't get there quite early enough, but still afterwards, that the body can recover via, physical therapy and medications that most people can recover in terms of gaining, whether it's speech back, strength back, quality of life back, correct?
I think that's a very important point you're making here, because while we're discussing this thing, we're talking about these interventional things to restore blood, but of course there's going to be areas that have been damaged as a result of the stroke, and you're going to have the deficits. And as we recognized over the years, is that the more aggressive you become with the interventions with the therapies and prevent complications from occurring, so too will the patient have a better recovery and minimal deficits in the end. So clearly, yeah, with speech, PT, engaged in that, and also all the other big things that usually would happen with, like the DVT, the aspiration pneumonias, UTIs, trying to prevent those will certainly help the patient move forward in terms of their recovery.
Yeah. And we have, kind of those services as part of our team here too, which is great. In terms of afterwards, speech and swallow evaluations to make sure that people are swallowing correctly, and if not, we can, get them plugged in with them, physical therapy and occupational therapy in terms of getting them back up, walking, gait, going to the bathroom, cooking, cleaning, correct. Driving.
Right from the get-go. We see this thing through the data we follow through the stroke center that, immediately they do the dysphagia screening. If there is identified stroke with a deficit, PT, OT are all involved right from the beginning. And at the end, you also do the end assessment to see what residual deficits and obviously where the patient needs to go. Is it long-term rehab, back to the home, and continue with outpatient therapies if necessary.
Do you see a time frame where there's or a time limit or frame where the interventions in terms of speech therapy, occupational therapy, and rehab is most effective?
Of course,
early, but then
early.
How long does it last? What's the potential for improvement?
That's a very good question, because in the past we used to say, after a certain amount of time, we'd say 1 year or so, that pretty much have plateaued and have recovered as much as you can. But the truth is that I've been doing this thing now a little over 20 years. And studies showing about the brain plasticity that even well years out after this thing, that you do see some continuing recovery from the stroke. Of course, it's not going to be to the great extent that it would be early on after the event, but certainly I don't think that you could discount anything just because of time.
Yeah, I think emotionally for patients to understand that too, that if you did suffer a stroke, that because it's devastating emotionally, right? They're really, upset in terms of whether it's trouble speaking, trouble walking in a lot of ways. But that with the right therapy, kind of, perseverance, that they can get back on their feet and kind of get back to the quality of life that maybe not exactly what they were experiencing before the stroke, but many of them can get pretty close to it and do quite well. So.
We have another question from Matt. We did touch on this. What are some of the early signs you can look for? So, as we talked about, some of those, modifiable risk factors, high blood pressure, high cholesterol, diabetes, smoking. So those are things you may not be able to feel, but certainly can control. And then early, signs of a TIA, any subtle neurologic change, numbness in your face, tingling in your hands, vision changes.
Yep, trouble speaking or
trouble
talking.
speaking, talking.
Eating.
And eating there.
Well, again, they kind of emphasize the point that anything that you're doing in bodily function, anything that's different from your baseline could potentially be that of a TI or a stroke. And I know they're kind of getting into this thing, but we think of like a complicated migraine, which is masquerading itself like a stroke. And can you turn around and pass out with a stroke and be thought of as a cardiac event or something? No, it could still be a stroke. So
Yeah.
I don't think you need to sit there and think about hard and fast. These are the absolute things related to it. Although, again, go back to what they try to point out with the acronym FAST. Still think of just anything that's different in you neurologically could be potentially
Yeah,
stroke related.
I think it's a good point in terms of how we were trained. I'm sure, just in terms of excluding the bad things first and then figuring out what it could be later.
And
There's
fastest.
a number of
Yeah,
things
sure.
that can
Yeah,
cause
yeah.
headaches, numbness, tingling, and different things. And they go from as serious as a stroke to as maybe insignificant as, could be a reaction to something, could be an allergy, could be, but better to find out early if it's a stroke to intervene on, and then
And let us figure that
and
out,
then
like you said. yeah.
afterwards
That's it.
tease
Yeah.
out
Right.
the other things that could be causing the symptoms. Absolutely. So, good. In addition to other things they look at in terms of when someone suffers a stroke, they kind of moving down the body. They often look at the carotid artery we talked about. They usually do there's a cardiac component to this in terms of not just whether the heart's in a regular rhythm or not, which is very important, but also whether there's sometimes there's holes in the heart that don't close. Correct? That can
Correct.
maybe put us at a risk for a stroke.
We're looking at the structure of the heart. It's all the structural issues about it, whether it's a valvular defect, whether you've had a previous MI, there's some wall motion abnormalities, a hole in the heart caused what is called a paradoxical emboli, et cetera, to allow clots from the venous side going into the arterial side. So there's a whole series of things that we're concerned about with the heart and its relation to stroke. Of course, in the detailed evaluation, this is something that my cardiology colleagues could speak to it, but we order the transthoracic echocardiograms or the transesophageal echocardiograms to interrogate the heart in that respect from its structural component, and then of course the electrical conductivity through the EKG and the Holter monitor that we pursue in evaluation.
And I've seen, you probably have seen too, in terms of against certain infections, in people who use IV drugs, in terms of there's bacterial infections that can affect the valves of the heart. Sometimes they can break off. I've seen kind of infective strokes. And the other thing too is sometimes looking at people's blood to make sure that they don't have a problem that's making their blood more sticky or what they call hypercoagulable. So there's a workup there in a sense too, because certain people are at a higher risk for clotting. They don't realize perhaps.
Correct. You're getting into an area that's a lot more, how would you say, extensive in terms of the evaluation of stroke, and you basically have to sort of tier it in terms of what you're going to look at. Specifically, if you're looking at stroke in the young, I mean, that's like the kitchen sink workup, if you will. So you do want to look at things like the coagulopathy profile, other autoimmune disorders, et cetera, the vascular anatomy. So it goes beyond just the regular things of like what are the secondary changes from high blood pressure, cholesterol, tobacco smoking. And in that, clearly would require different investigations and perhaps even different therapies for that.
I guess I think my point was just bringing it up, and again, obviously we just how lucky in terms of we work for an organization where we have all these different components to tease these things out. I mean, we have your whole brain and spine center team in terms of neurology, we have the cardiology team, we have the vascular surgeon team, we have hematology and the blood specialist working with us in our hospital, so it really
absolutely.
It's amazing how many things can contribute to a stroke in terms of and how complex it could be, and so again, back into your point about just making sure it's addressed, because it could not only just help you save and treat the stroke itself, but also perhaps identify a whole, other, set of problems that could be contributing to it that you may have to date gone undiagnosed.
Absolutely, and I think that's a very important point where we do rely a lot on each other in terms of our subspecialties. Something may come up in the investigation that we don't know whether this thing has any validation in terms of the stroke mechanism, and many times we're cross-collaborating with each other in terms of do we really look at this thing as something real, and how do we best approach the matter.
I think that's actually one of my favorite parts about practicing, certainly at Southcoast, is working together on these things, especially because they're, having a common medical record that we could send messages to one another. You know what I mean? There's good things and bad things about the medical record in terms of how we practice. But I think one of the benefits is at least be able to all see each other's charts and notes and, call one another or message one another and kind of help move the patient seamlessly as much as possible through the different offices or centers that they need to get to, which is really nice.
We had a comment from June, who is a patient of yours, and she said that she had a TIA about 4 years ago, and her son noticed that her smile was crooked. So you did a good job imparting on them, any subtle changes, don't hesitate. So we are all caught up on questions now.
Nice.
Do you have any kind of, parting words or anything that you wish that anyone would, everyone should know about strokes or in kind of the services that you...
I will say this, that, again, going back to when I was originally training in neurology, I felt that this was sort of a dead-end thing, that stroke was basically thrown on the wards, trying to minimize their complications related to the stroke and try to prevent the next one from happening. It wasn't until we started getting to TPA and now with thrombectomy that we're in a very good time with the treatment of stroke. But the thing here is that it's a mutual, collaborative thing with the treatment process, that we need the patients to come to medical attention as soon as possible. We only have a very finite time in which we could do this interventional
and that
process.
time again is how many?
For TPA, they say up to 4.5 hours. For the thrombectomy thing, between 6 and 24 hours. So this is
yeah.
So don't ignore your symptoms.
Yeah, so it's important, right? So,
Yeah.
because so if symptoms happen before going to bed, don't go to bed on it. Like, don't sleep on these things. Address them. Don't wait till the end of the day at work, right? So people are afraid to, I think actually, and I've lived this as a parent, as like a caregiver, knowing when to go to the emergency room, like outside of the setting of like a major car accident or something. People don't know when to pull the trigger and go to the emergency room. They kind of, geez, I don't know. It's probably fine. I can probably make it through work, but. I mean, I think the parting, hopefully, goal that we get to communicate tonight is don't. You know what I mean? In terms of there's a change, don't pass go.
Don't pass go. You can have a secondary phenomenon here where the stroke extends itself. Then you get into the complications of this thing. So it's not just what we do, the acute intervention, but also try to prevent the complications from setting in.
Mm-hmm.
And this could be from the neurological thing of what happens as the natural evolution of the stroke itself to the medical complications associated with stroke. So it could potentially minimize the damage, and that's the whole basis here.
And we're lucky to have, all of those interventions right at our fingertips here.
Yes.
With all
Yes,
of the hospitals
absolutely.
here.
In the hospital and outside of the
And
hospital,
outside
right?
of
So
the hospital,
we're really well positioned to take care of you in the emergency room, in the hospital to get this done. And afterwards, when things are stabilized, to come back, we can get you plugged in. And we work with them all the time in terms of our office and caring for them, and then with your team as well, which is great in terms of managing the stroke afterwards and making sure, hopefully, reducing the risk as much as possible from another stroke and getting them back on track. Correct?
Correct.
We have one final question from Linda asking, can TPA help blockages in the carotid arteries? It's a different type of blockage. So I think the TPA would, does the TPA help, open up the carotid arteries at all, is her question.
So I suppose that if a patient came in and had neurological deficits and was within the time window of less than 4.5 hours, and you didn't get the carotid ultrasound, I don't think that they would not give you TPA and then ultimately discover that you had some kind of severe blockage in the carotids. It's not that TPA reperfuses large, although it does, but not to that extent, reperfuses large vessel occlusive strokes. But nevertheless, it's not that just because you have had a carotid event, you're not going to get TPA.
Right, and carotid, the narrowing of the carotid arteries is due to kind of, high cholesterol and hardening of the arteries, where the TPA is more focused on busting that kind of clot. That's, so it's a clot versus, kind of longer term changes in the
concept could be
arteries.
much the same, that you could have had the buildup of plaque. The plaque dislodges, now opens this area of the vessel wall to form the clot and cause your occlusion there, which TPA could theoretically help with this thing. Correct.
So again, for just recapping, we hope ideally the goal is maybe to prevent as many strokes as possible. So things that people can control when we try to empower our patients and people who watch: not smoking, making sure you know what your blood pressure is by either, hopefully seeing a primary care doctor or having your blood pressure checked either at your pharmacy or in the supermarkets to make sure it's not elevated. Making sure you're exercising, eating kind of a healthy diet. Knowing what your cholesterol is to make sure if it's elevated, because you usually will not have any symptoms of high cholesterol, so making sure you're getting your cholesterol checked and it's being controlled. And then if you have other additional risk factors, whether it's a family history or a history of heart disease, getting those addressed as well. And then if something, again, if it comes up, don't wait, go to the emergency department.
Exactly, and I hate to, in this forum, start using academic numbers, but the idea is that 80% are preventable through these
Really?
these
That's
approaches.
phenomenal. No, we love that.
Yes.
I mean, that's great.
We'll use that every
Secondly,
day.
Yeah.
And on the flip side of this thing, when you think about this, that every 40 seconds somebody's having a stroke in this country. Every 40 minutes somebody's dying from a stroke in this country.
Yeah.
So these are very profound numbers, and if you could jump on this thing and do the preventative thing, yeah, you could.
One last topic, and I hate to at the end of the show: aspirin, in terms of taking it to prevent strokes. We, in taking care of patients based on their risk factors, it helps reduce the risk of certain strokes. Correct?
Correct. It's one of the first line of preventative therapy in terms of, let's say, antiplatelet agents and low-dose aspirin. And we start off at 81 milligrams and move it up from there. I know that they've looked at different doses over the years, but clearly, after 81, 325, then you start moving on to the other antiplatelet agents.
Yeah, I think it's important to put out there if to talk with your doctor or nurse practitioner or about if you're a candidate for adding aspirin to your medication regimen to help reduce your risk of stroke. Because we certainly talk about it with our patients, and it's another thing in addition to all the things we talked about, but maybe perhaps adding an extra layer of protection against reducing the risk of stroke.
Stroke, but certainly our cardiology colleagues are strong proponents of this thing, so it's not unusual that we see patients already on some form of antiplatelet therapy.
Hannah, anything in the queue?
No, Linda just said how much aspirin, and I think you just said 81 milligrams was kind of been the easy number.
If you're aspirin naive, correct.
Yeah.
They usually start off at 81 milligrams and go up from there. I have a more of a different stylistic approach relative to the individual's risk factors, age, etc., or whether it's a TIA or stroke, or how big of a stroke, etc. I may play around with it differently, but I think the fundamental principle here is to start off at the recommended doses of 81 and move up from there.
Good. We want to sincerely thank you for coming on the show.
Thank you.
And taking an hour out of your busy life to talk about strokes and helping kind of educate people about it.
And we're going to take another hour in the future to talk about
If
headaches.
it's okay with you,
Full
hopefully the show went
hour
well
on
enough.
headaches.
We'd love to have you back to talk about
Absolutely.
headaches. And we also, I want to thank, on behalf of Hannah and I too, thank you so much for taking care of our patients together with us. I mean, it really is a tremendous resource, and we feel really lucky to have you help in caring for our patients together. It really is a privilege to work with you, and so thank you. And if you would come back on to talk about headaches, which is something we see and collaborate, I think, a lot on as well, we would welcome you back, because I'm sure there's a lot of headache patients out there as well.
Absolutely. I think that's one of the main bread and butters in ambulatory neurology that that we're seeing. Deserves its own hour.
Good.
I would say.
Good.
Just in closing, we just want to remind people again about the new wound care center that has opened up at St. Luke's Hospital, dealing with the full scope of wounds, and it's great. So the patients no longer have to travel to Fall River to receive their services. It's located on the mezzanine level. And also our website, there's resources in case you didn't missed it earlier in terms of specific kind of patient-oriented readings regarding medical problems, so you could kind of have a validated source of good information, and that's on our website. And if you just click under the resource tab. And finally, regarding support groups are also on the website, so if you've suffered the loss of a loved one or experiencing certain medical conditions, we have a number of groups that meet throughout the month. You can check that out as well. And also, it's that time of year, school camp forms, get them done. I'm going to go home and do mine tonight. And if you need help with physicals, and you can reach out to one of our primary care offices or our urgent care centers to help get those completed. And you can go onto the website to help schedule those as well. And I want to thank you, Josh, for another great show. And Hannah, thank you very much. John, thank you again.
Thank you.
Yeah.
Stay healthy, South Coast.
I became a fisherman. I used to scuba dive for quahogs, and that was heavy work. When you're self-employed, you gotta keep going. I kept hurting my back. Then I found out I have degenerative disc disease. I deteriorated to the point that I couldn't stand up. The pain was just so severe. It affected me emotionally, psychologically, and physically. I had probably 12 surgeries, and I wanted to give up. The pain was just so bad. When there's no relief in sight, what else do you have? My general physician, I went to him, I told him I wanted to go to Boston, and he said to me, before you go to Boston, I know a guy at Southcoast Health. So we met with the neurosurgeon at Southcoast Health, and he told me what he was going to do. That's when I started to get happy. The pain had subsided. I wake up happy. I go to bed happy. I can stand up. I saw my surgeon 6 weeks ago. He says, Bruce, you're doing well. And I said to him, you saved my life. And without you, I don't know what I would have done or where I would be today. Yeah, there's a lot of tears, even on his part. I can't tell you how much of a difference it's made in my life. It's totally different. Now, bring it on. Life is good.
By the time I graduated high school, I think I was between 275 and 300. I had to buy my dress clothes at the Big and Tall store. Enough is enough. Southcoast Health gave me the tools, and here I am, with my health. And I was a 46 going into 48, and now I'm a 30-inch waist. I'm living proof to show if you put the work in on anything that you can get what you want. Take impossible, throw it out of your vocabulary.